Good evening, everyone, and welcome to today's webcast, Novel Mechanism of Action in the Treatment of Moderate to Severe Plaque Psoriasis, sponsored by Orthodermatologics. My name is Corinne Pettit with the National Psoriasis Foundation, and I will be your moderator for tonight's presentation. Before we get started, I'd like to go over a few items so that you know how to participate in today's event. You should all be logged in to GoToWebinar and see a control panel on your computer's desktop screen in the upper right corner. You've joined the presentation listening using computer speaker system by default. This means that if you can hear music through your computer, you should be able to hear the presentation. If you prefer to join over the telephone, just select Use Telephone in the audio pane and the dial-in information will be displayed. We also have attached a handout and included a link in the chat box if you'd like to know more information about prescribing information for Saliq. You will have the opportunity to submit text questions to today's presenter by typing into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and address as many as possible at the end. This webinar is being recorded, and you will receive a link to the recording following today's presentation. I would now like to introduce Dr. Stefan Weiss, founder of Weiss Skin Institute in Florida. Welcome, Dr. Weiss.
Great, thank you very much. And first, I want to thank the NPF for organizing this and for doing so much for patient education and patient advocacy. It's a tribute to think about all that's been accomplished over the last 15 to 20 years in the development of drugs for psoriasis, largely spearheaded by their efforts and their compassion for individuals with psoriasis. Additionally, I want to thank Orthodermatologics, not only for producing this medicine that we're going to discuss today, which is phenomenal for patients, but also for sponsoring this opportunity to sit down and have what I like to call a fireside chat with a lot of individuals who suffer from this disease. So with that, I just want to make the statement that it is a promotional program sponsored by Ortho, and I am presenting on behalf of Orthodermatologics. This is not a continuing medical education event. I am a consultant for Orthodermatologics, and the full prescribing information for Saliq, including the box warning about suicidal ideation and behavior, as well as the medication guide, can be accessed at the link in your chat box. As we sit down and we prepare to spend the next 45 to 60 minutes together, there are some core goals that we should really think about because it's important that you get a lot out of this presentation. We want to review the symptoms and challenges associated with plaque psoriasis, which I'm sure many of you know day to day and don't really need me to tell you about. We want to discuss a treatment for plaque psoriasis that works differently from other psoriasis medications. As I always say, I've not been in this game very long, but I've had the pleasure of seeing all of these medicines come to fruition from the time when we had no biologics for psoriasis to where we have almost 10 and probably another 10 out there on the horizon to treat this disease. We want to cover the important safety information about this treatment, and we want to provide information and resources to help support you in your journey to clearer skin, because that's really what's important here. And what our focus is, both mine as a physician, Orthodermatologics as a corporation, and the NPF as the patient advocacy group, is really to make sure that you as a patient with psoriasis are supported, heard, understood, and given treatments that will make you better. So let's just look at an overview of psoriasis just to understand where the disease is and how we can treat it. So just some general facts about the disease. We all know what it looks like. It's raised red scaly patches on the skin. You could have as few as one on the elbow and as much as 90% of your body covered with it. As you know, but so many people without the disease don't, psoriasis is not contagious. The lesions are not infectious, and it's unfortunate when we think about how many psoriatics are ostracized because of their disease based on the fear that indeed it is contagious. In fact, the great American author John Updike talked about his psoriasis and labeled it Journey of a Leper to explain how he felt with this disease as he was interacting with his individual colleagues and friends. And so I know what you guys suffer through. And it's totally unfortunate because all we need to do is get a little bit more information out there to the general public. As you know, it often develops between the ages of 15 to 35. And in fact, about a third of people with psoriasis have a family member with the disease. Indeed, if you have two parents with the disease, there's the chance of upward of 50% that a child will develop the disease. Today, it affects more than 8 million Americans, and men and women are affected equally. Now, a lot of patients come to the office, and you may confront this as well, trying to figure out what type of psoriasis they may have. So they see their skin, they listen to the TV commercials, they go on the internet and do a little bit of research. There are a variety of types. The most common is plaque psoriasis, and that's what we're going to talk about mostly today, because all of the medicines that are currently available have been developed and are indicated for the treatment of plaque psoriasis. It appears as raised red patches covered with silver-white buildup of dead skin cells. It is that red silvery scale that is the pathognomonic hallmark of the disease, and it is that silver scale that we often find on our bed sheets, on our carpets, on the top of our shirts and jackets. A totally different type is called guttate psoriasis, which appears as small dot-like lesions. That often starts in childhood or young adulthood and is considered to be triggered by a strep infection. And many individuals who develop guttate psoriasis due to a strep infection clear relatively quickly once the infection is treated and are never bothered by the disease again. Inverse psoriasis is that which appears as a red lesion in the fold, so in the groin, behind the knee, under the arms, under the breast. Because of the moisture in these areas, the skin doesn't get that silver scaly plaque, which is great. So it totally changes the disease. It oftentimes goes misdiagnosed or underdiagnosed because of how different it is from general plaque psoriasis. But again, it's very important that you are perseverant with your provider if they are treating it as potentially intertrigo, that you're getting the right treatment and it's recognized that in fact you have a form of psoriasis. Pustular psoriasis is exceptionally rare, but that appears as white pustules, which are considered blisters of non-infectious pus. So if you think about what a pustule is, it's as if you got a fluid blister, but instead of being filled with the clear fluid, it's cleared with a little bit of this white, milky material. It's often surrounded by red skin, frequently occurs on the hands and feet, and has a variety of other names. It's unclear that the disease process is the same as generalized plaque psoriasis, but it falls under that large rubric of psoriasis. And last but not least, erythrodermic. This is an exceptionally rare form of the disease. It can be very severe, often requiring hospitalization, but it's a fiery, widespread redness over most of the body. And this is a disease, as I said, that really requires urgent treatment from both dermatologists as well as hospital personnel. So let's think about how severe your psoriasis may be. You ever wonder how you qualify for one of these drugs, or when you watch a commercial, it may say, do you have moderate to severe psoriasis? Well, if you think about your palm and you look at it closely, it represents roughly 1% of your body surface area. So if you take your palm and you place it across the different areas where you have your psoriatic plaques, and add that up, you can gain a relatively rough estimate of the amount of disease that you have. So we consider mild psoriasis to be that which covers less than 3% of the body. We think of moderate psoriasis is that which covers 3 to 10% of the body, and severe psoriasis is that which would cover greater than 10% of the body. Now, I'm sure there have been times when you're absolutely clear of your disease, again, whether you have mild, moderate, or severe, and then all of a sudden, out of nowhere, multiple plaques emerge. And you probably wake up and you think to yourself, why am I having this now? I was so well controlled for so long. What's triggering my psoriasis? Well, indeed, there are a great deal of possibilities that would be leading to that trigger. One, of course, is stress. And we know that there's a tremendous correlation between stress and skin disease, specifically psoriasis. There's a whole field of research called psychoneuroimmunology that looks at the impact of stress in psoriasis. And we know in general that psoriasis is a stressful condition. And unfortunately, as it flares due to stress, that sort of creates this backward cycle. The individual becomes more stressed about their disease. The disease continues to get worse. So we always need to break that early. And when you do find yourself flaring, even on good therapy, it's an opportunity for you to contact your dermatologist to make sure that you're seen and this cycle is interrupted quickly. Injury to the skin, so sunburns, scratches, and other skin injuries can trigger your psoriasis. What we find oftentimes is something called the Kebner phenomenon. When you scratch the skin or you injure the skin, you can develop a plaque of psoriasis in that site of injury. There are a whole host of medications that can trigger psoriasis, including lithium, antimalarials, beta blockers, quinidine, and indomethacin. Thus, when you talk to your primary care doctor or you switch primary care doctors, it's always important to talk about your skin disease and let your physician know that in fact you do suffer from psoriasis so that they can gauge what other medicines you may require for other medical conditions. Infection is a very common trigger for psoriasis. As we discussed previously, there's a whole form of psoriasis gut tape that's secondary to a strep infection. And this is when we see that disease in children following a bout of strep throat. You can get something as simple as an earache, bronchitis, respiratory infections. Any one of those can make your psoriasis worse. And then, of course, there's a lot of other triggers that we talk about but don't really have a great deal of scientific evidence. Allergies, diet, and even weather can make people's psoriasis better or worse. But in the end, researchers believe that development of psoriasis results from a person carrying one or more of the genes that cause the disease and being exposed to specific external factors called triggers. And that's really the main takeaway. That again, this is not an infectious disease. This is not a contagious disease. Nobody can catch it from you and you can give it to no one. It is a genetic disease, which is why we see it more commonly in families. And what a lot of the research today is going to understand these genetic markers, which allows us to continue to develop better and better therapeutics. So people with psoriasis are at a higher risk for other health conditions. Again, why it's so important for you to discuss with your primary care doctor the fact that you suffer from psoriasis. Again, even if it's a plaque on the elbow and you don't think much of it, it's critical that that gets mentioned to your primary doctor during your annual physical. Because people with psoriasis can develop cancer, type 2 diabetes, cardiovascular disease, depression, obesity, inflammatory bowel disease, metabolic disease, and of course, arthritis. So again, it's really critical that you engage with your primary care doctor when meeting him or her for the first time or during your annual physical to discuss your psoriasis. One of the things that was talked about in the previous slide that it's worth mentioning again is the correlation between psoriasis and depression. So indeed, in a large study of more than 12,000 people, 16.5% of patients with psoriasis met the criteria for a diagnosis of major depression, which is understandable. I mean, think back to the times, especially for those of you in this discussion that have moderate to severe disease, and think back to the time that maybe was before you were on a biologic or before you were on systemic therapy, when 10 to 15% of your body surface area was affected by the disease, and we in medicine had no really good treatments other than some topicals. And maybe somebody was less than kind to you because of your disease. Think about how that made you feel. And understand that a large percentage of individuals like you with moderate to severe disease can develop depression. And we understand what that is. So not only do the stigma of visible psoriasis make people depressed, but there are potentially biologic changes in individuals with the disease that may also cause depression. Depression can have a significant impact on quality of life, and people with psoriasis are more likely to have suicidal thoughts and even attempt suicide. So it's very important to always look out for these symptoms and seek treatment if you need it. You're not alone. Dermatologists are aware of these correlations, and we're here to help. And one of the reasons that we've been so thrilled with the development of so many therapies, Siliq being the latest, is because of how great they are in helping people clear their skin. And we truly believe that as the skin clears, people feel better about themselves, their quality of life improves, and the depression abates. But it's always important to remember that psoriasis is more than just skin deep. And so the question is, what's driving it? We've established the fact that it's not infectious. We've established the fact that there's a genetic link, but what is that genetic makeup creating? So psoriasis is a disease that starts inside the body. It's considered an autoimmune disease, meaning it's your body attacking itself. When this occurs, when the immune system goes into overdrive, you develop inflammation. inflammation leads to the overproduction of skin cells, and when the body cannot shed those skin cells fast enough, it leads to the red, flaky patches called plaques. So if you want to think about it in the ways of a more common example, it's as if you were continuing to try to put sand on top of each other without any wind. The sand would just continue to grow, and that's how you can create a sandcastle up until the ocean comes away and sweeps it up. So again, much like your disease state, the skin turns over at a standard rate and clears it at that rate so that the skin stays relatively normal in appearance. In psoriasis, the skin is turning over so quickly that the body can't clear it fast enough. So essentially, like the ocean is not coming in fast enough to wipe out your sandcastle. To stop the inflammation process, therefore, psoriasis treatments must work from within, well below the surface of the skin. They need to target the source of the inflammation. So I don't need to tell most of you on the call, there are many different types of treatment for psoriasis. Topicals are always the first line. Corticosteroids in so many forms are used. But in addition to that, we have a lot of non-steroidal treatments, including salicylic acid, coal tar, vitamin A, vitamin D, aloe vera, capsaicin. Light therapy is very common. It's been used for decades with very good results, where individuals are exposed to ultraviolet light on a regular basis, both UVB, UVA, narrowband UVB. It can be performed under medical supervision. It can be performed at home with home light boxes. A lot of opportunities for light treatment for psoriasis. Then clearly systemics, which are given orally or by injection. These are relatively restricted to moderate to severe disease, and often in patients who do not respond to topicals or light therapy adequately. Biologics are a type of injection or intravenous infusion that are used in moderate to severe disease and used in patients who do not respond to other therapies. The reason they're called biologics is because of the production. They're produced in a biologic manner in cell culture. So unlike your standard pills or other injectable medicines that you may have used previously, like methotrexate, an injectable biologic is such because of the way it's produced. And then there are a lot of newer oral treatments that are taken by mouth. And unlike some of the earlier pills, again, referencing methotrexate, they selectively target molecules within the immune cells. So with that, allow me to introduce Siliq, which goes by the name brodalumab. So it's a monoclonal antibody injection. So this is a biologic treatment for psoriasis that works in a unique way. So the question obviously emerges, what is Siliq? Well, Siliq injection is a prescription medicine used to treat adults with moderate to severe plaque psoriasis. These are individuals who may benefit from injections or pills, systemic therapy, or phototherapy, as we talked about, using ultraviolet light. And they have tried other systemic therapies that didn't work or stopped working. Siliq has not been evaluated in children, so one cannot comment on whether it's safe and effective in those under the age of 18. So one of the most important things we need to know about Siliq, and as we referenced earlier, is the notion of suicidal thoughts or behavior. Some patients taking Siliq have had suicidal thoughts or even ended their own lives. The risk is higher if you have a history of suicidal thoughts or depression, and it is not known if Siliq causes these thoughts or actions. What that means is they did not establish a causal link between the drug and the thoughts and actions. It goes without saying, you or a family member notices that you have any of the following symptoms, including new or worsening depression, anxiety, mood problems, thoughts of suicide, dying or hurting yourself, attempting to commit suicide, or acting on dangerous impulses. Any other unusual changes in your behavior or mood should be discussed with your dermatologist. Your healthcare provider will give you a Siliq patient or wallet card about these symptoms that may need medical attention right away. And it's important that you carry the card with you during your treatment with Siliq. And again, like your psoriasis, you should always discuss this with all of your healthcare providers. Some other things that are important to note when you're taking Silique is the risk of serious infections, and this goes with all psoriatic treatments of the biologic nature. Silique, because of its ability to treat the disease by altering the immune system, can lower that ability of your immune system to fight infections, and therefore may increase your risk of infections. Your healthcare provider should check you for tuberculosis before starting treatment with Silique, and may treat you for tuberculosis before starting Silique if you have TB or a history of it. You and your healthcare provider need to watch closely for signs and symptoms of infection during treatment with Silique, including fever, sweats, chills, shortness of breath, stomach issues, muscle aches, cough, sore throat, or trouble swallowing. You can get warm, red, or painful skin sores or burning while urinating or more frequent urination. So again, it's always important whenever you listen and learn about any of these biologic medicines for psoriasis or medicines in general, that there are some tremendous positives that come with them, specifically in this case, the clearance or near clearance of your skin. But you always want to watch out because there are side effects that need to be monitored and appropriately managed. So there are a collection of individuals who should not use Silique, and that's specifically if you have Crohn's disease. So if you have a diagnosis of Crohn's or you suspect Crohn's due to changes in your bowel movements, you want to make sure that you mention that quickly to your dermatologist. Again, before starting the drug, you want to tell your healthcare provider, like I said before, if you have Crohn's disease, if you have any history of mental health problems, including suicidal thoughts, depression, anxiety, or mood problems. You want to mention if you have an infection that does not go away or may keep coming back. If you have tuberculosis or have been in close contact with somebody with tuberculosis. If you've received or are scheduled to receive an immunization, specifically live vaccine. So this is always important during flu season. If the standard flu shot is okay, that's an inactive vaccine. But the vaccine that's given as a nasal spray is a live vaccine, and you should avoid that when you're on Silique or any of the other biologics. If you are pregnant or plan to become pregnant or breastfeeding, we have no knowledge of whether Silique can harm your unborn or newborn baby, so you want to discuss this with your provider before starting this or any other medicine. And tell your healthcare provider about all the medicines you take. And this is important for not just prescriptions, but also over-the-counter medicines, vitamins, and herbal supplements, because we want to make sure that there's no interaction. In terms of the use of Silique, you want to see the detailed instructions for use that come with the medication, specifically on the way to store, prepare, and give yourself the injections at home, and how to properly throw away of any of the Silique pre-filled syringes once they've been used. And of course, you want to use the medicine exactly as your dermatologist has explained to you. As we mentioned before, in terms of side effects, there can be some serious side effects, specifically infections, as discussed. And you can always read a lot more about this in terms of what would be the most important information you should know about the drug and who should not take it. What was seen in clinical trials in terms of the most common side effects included joint pain, headache, tiredness, diarrhea, mouth or throat pain, nausea, muscle pain, injection site reactions, flu, low white blood cell count, which is called neutropenia, and fungal infections of the skin. You always want to call your doctor for medical advice on these side effects should you think you're developing any while you're on the therapy. And you're always encouraged to report negative side effects to the FDA at fda.gov/medwatch. So Silique works differently than other psoriasis medications. And I think a lot of you on the phone have probably been on TNF-alpha inhibition. You may have been on medicines that inhibit IL-12 and or IL-23. And in fact, some of you may have been on medicines that interact with IL-17, the antibody. But Silique is the first and only IL-17 receptor A blocker. And so what we're going to do is we're going to look at how Silique gets beneath the surface to see how it works with this very informative video. So what you can see here is that Silique is working by taking the activated immune cell, which then becomes the Th17 cell, and that differentiates into three different factors: IL-17A, IL-17C, IL-17E, and IL-17F. And those cells then circulate in the body until they bind to the receptor. And so when you think about it, it's sort of like a lock and a key. And IL-17A, 17C, E, and F are all the different keys that fit into the lock of the IL-17A receptor. And so if you want to keep somebody out of your house, you have two choices. You can take away their key, or you can essentially block or change the lock. And what the other IL-17 drugs do is they take away one of the keys. Specifically, they take away those people who are carrying the IL-17A key, so they can't put it into the IL-17 lock. What Siliq does is it actually just blocks the lock. So if you're carrying an IL-17A key or an IL-17F key, it doesn't really matter because the lock is not available to you. And in so doing, by, as you can see right here in this picture, blocking the receptor, so blocking the lock, those circulating antibodies that may be coming because of the activated immune cells can't really accomplish anything because they can't get into the door that causes the plaque of your psoriasis. So as you can see here, the IL-17F and the IL-17A and F, they sort of spin around and they hit the tape that's on the lock, which is the Siliq, and they just bounce back into the circulation, so they can't actually do anything. And that's where this drug differs when compared to some of the other ones that are out there that, as I said, target the key rather than the lock. And because of that, for many patients, Siliq is a path to rapid lasting results. Indeed, Siliq reduced the redness, thickness, and scaling of psoriasis plaques for many of the more than 4,400 people who used it in clinical studies. In brief, 8 out of 10 individuals had 75% clear skin at 12 weeks. 7 out of 10 patients with 100% clear skin at 12 weeks, in fact, remain clear at 1-year follow-up. 4 out of 10 patients had 100% clear skin at 12 weeks versus 2 out of 10 Stelara patients. And I'm sure that there are many of you on this call that have been on Stelara or are currently on Stelara. And so you know how the drug works, how it works for you, how it works maybe for some friends. Now think about Siliq getting twice as many individuals 100% clear skin at 3 months. And the other nice thing about Siliq is the speed at which it acts. In fact, improvements were seen as early as week 2. But that's a lot of science, and unless you're an immunology major in college, you may have been bored with a lot of that. And what the reason you're here is not to hear necessarily how it works in the aggregate, but how does it work for real patients? And so I think it's nice that we can discuss some real patient journeys with the drug. Because treating moderate to severe plaque psoriasis with Siliq has shown dramatic results. And what I want to share with you now are these real untouched photos of patients who had been treated with the drug during the clinical trial. Of course, it's always important to note that individual results may vary. Remember, 8 out of 10 had 75% clear skin at 12 weeks. 7 of 10 with that clear skin remained clear at a year. So this is what the preponderance of people on the drug responded. But again, that may differ for all individuals. So let's think here. Patient A, before the trial began, had what's called a PASI score of 29.6. So that's something that we use in the research field to assess the severity of the disease. So PASI stands for Psoriasis Area and Severity Index. It's an objective measure that clinical trial individuals use and the FDA understands and is able to take that and put it in a quantitative format such that drugs can be reviewed for their safety and efficacy. And what you can see in this person is at 12 weeks, a PASI response of 81% was achieved, meaning that 29.6 PASI score dropped by 81%, or was essentially back down to roughly a 5. And then at 52 weeks, the PASI response was 96%. So essentially meaning the PASI score was about 1. So it's pretty remarkable that at 12 weeks, an individual had an 81% response and was virtually clear at the end of the year. So again, underscoring what we talked about earlier, that 8 out of 10 individuals had 75% clear skin at 12 weeks. So let's look at patient B, another individual with pretty robust disease, as we can see here in this initial picture, PASI score of 40.6, which is significantly severe disease. Amazingly enough, at week 12, the individual's PASI response was 89%. You can see that the thickness of the plaque is virtually gone. The B has been replaced with some very pink erythema, and there's no real scale. It's denoted on the picture. By the end of the year, you can see that individual had a PASI response of 100. If you look closely, even that faint pink erythema that's in the central part of the stomach and chest is totally gone. And what this suggests again is that more than 4 out of 10 people had 100% clear skin at 12 weeks. So as we look towards patient C, what we see is that classic silvery scale on the knees and shins with a lot of the red scaly plaques extending from the knee down to the ankle. This individual had a physician's global assessment of 3, and so that's considered a moderate to severe disease. So when we think about how we would evaluate an individual within a clinical trial, PASI is the way we do it for the most part because that's quantitative. Physician global assessment is a bit more qualitative, but it's probably more significant to you as patients and to clinicians worldwide because they assess their patients as having disease that's maybe mild, moderate, or severe. They're not going to get engaged in calculating a PASI score unless it's for a research purpose. And you as a patient look at your skin and you say, I have mild disease, I have moderate disease, or I have severe disease. So this individual was considered to have a moderate to severe with an assessment of 3. At 12 weeks, it resolved to 1, and at 52 weeks, it stayed at 1. So going from moderate to severe to relatively mild by the end of the year. And so that was considered clear or almost clear. So we think of clear as a global assessment of 0. We think of almost clear as a global assessment of 1. And in that case, 7 out of 10 individuals had achieved that clear or almost clear at 12 weeks. So now we'll move on to patient D. So as we can see in this individual, and I always like to say for those of you who have participated in some of these NPF webinars before, no psoriasis talk is complete without somebody in the blue underwear. We in research like to use this because it gives us a standardization of our photos. So before, you can see pretty significant disease on the back and buttocks. By 12 weeks, 98% PASI improvement. So essentially meaning that the individual is virtually clear, and indeed, by the end of the year, this person had 100% PASI achievement and was considered completely clear. So really quite a phenomenal response for pretty significant disease at the onset. But what's important is not just getting these drugs developed. As I always say, a drug that's phenomenal does nobody any good if they can't get it. And what orthodermatologists have done is really create an opportunity to support you in your journey to clearance in getting the medicine. So how does one take Plaque? So should your physician and you decide that Plaque is a good option for your disease state, it's given as an injection under the skin, or what's called a subcutaneous sub-Q injection. Importantly, it is a pre-filled syringe and not an auto-injector pen. So many of you who are used to some of the TNF-alpha blockers are familiar with the auto-injectors. This is actually a pre-filled syringe I know many people worry about the pain of taking a shot. Again, I can't state for certainty with everybody, but should you give it to yourself relatively slowly, it should not hurt. There may be some discomfort initially, but again, it's something that usually can be abated by the speed at which you inject. The way it starts is with one injection each week for the first 3 doses, and after that is simply 1 dose every 2 weeks. If you don't improve within 3 to 4 months of treatment, your physician may decide that it's not the right treatment for you. But again, based on some of the other patient journeys that we just saw, the good majority of individuals on this drug have dramatic clearance and then have dramatic clearance relatively quickly. So like all the psoriasis drugs, there's what we call loading dose, and that's what you do once weekly, and then your maintenance dosage is every other week thereafter. Now, if your healthcare provider does decide that you or a caregiver can give the injection at home, it's important you get trained by your healthcare provider on the right way to inject the medicine. So you can not only gain that information from your dermatologist's office, but you can read some of that information in the medication guide that's down in the package insert. On Salique.com, there's an instructional video about how to inject it, and your healthcare provider, as I said, will show you how to prepare, inject, and dispose of Salique. It's important that you don't try to inject yourself before getting this training, even if you have experience with some of the other biologics. Importantly, is a program called Salique Solutions, and this gives an instant savings on Salique for those who are commercially insured individuals who are eligible for it, and it's also assistance with the process of getting the medicine. And probably the nicest thing is the one-on-one nurse support to answer questions about injecting the medicine. So if you forget what your provider explained to you or you're a little bit nervous, you can call Salique Solutions and speak to a nurse about how to inject the medicine. In the end, orthodermatologics is committed to ensuring that the effective options are available to combat the effects of moderate to severe plaque psoriasis. So it's important to the individuals at the organization that nobody should be denied this medicine for reasons necessarily of cost, because everybody from the company to your dermatologist to the NPF is committed to making sure that you don't have to suffer from this disease, and the way to not suffer from the disease is to gain access to the medicines like Salique. So if you have financial needs and can't afford the medicine, or it's not covered by your insurance, Salique Solutions is often able to help, specifically if you meet the eligibility criteria. You can fill out the patient assistance program application, also available at Salique.com, and bring it to your doctor's office and your dermatologist, and you can submit the paperwork to the appropriate individuals to determine if you would qualify for this assistance. So you want to ask your healthcare provider if Salique may be an option for you, and your healthcare provider can help you create personalized goals for your treatment. And that's always important because everybody needs to figure out what they are looking for. And you want to consider these questions before your next visit so you can have an effective and meaningful conversation with your dermatologist regarding your psoriasis. One of the most critical questions is, how is your psoriasis affecting you? What you want to think about is it impacting your job? Is it impacting the way you interact with others? Where is the disease? Is the disease noticeable? And I think a lot of that will drive your choices for medicine. You may be satisfied with topicals. You want a topical that comes in a better vehicle, or is a hybrid combination of 2 medicines. Or you may say to yourself, my disease is pretty severe. I'm tired of living with it. I'm getting ostracized at work or school, and I want to clear that disease. So a systemic option like Salique may be best for you, because you want to know, is clearance your goal? And if clearance is your goal, you and your dermatologist want to identify a treatment that has clearance as a possible option. Are you satisfied with your current treatment? How did your previous treatments work? Again, these are really important conversations to have with your dermatologist so that a new treatment can be identified, or potentially one of the older treatments that you were on before can be reinstated. And last but not least, what would you like to achieve with treatment? What are your goals for the time you're with your dermatologist, and what are your goals for that treatment? Because if you set those out up front, it's a lot more productive of an interaction between you and your dermatologist, not just in that initial visit, but over the long run. If everybody knows what you're striving to achieve, it's a lot easier to maintain that goal. For some individuals, it's about convenience. For some individuals, it's about efficacy. For some individuals, it's about safety. And these are really important conversations to have because, as I said before, the nice thing is today we have a multitude of options. And when I started in dermatology, unfortunately, we didn't. And for me, it's great. I mean, I love the fact that when a patient comes into my office with psoriasis and says, "Doc, I want to be clear of this disease," that I have the options to give him or her to achieve that level of clearance. When I was a resident, I didn't have that option. So we think about some resources that you have for dealing with your psoriasis. First and foremost is the National Psoriasis Foundation, which you can access by going online at psoriasis.org. For those of you who are not members of the NPF, I strongly encourage you to join. It's a phenomenal group of individuals who are some of the most caring and compassionate people I've ever had the opportunity to work with. They are truly committed to making sure that your disease is treated in an appropriate way, that therapies are available to you, not just from the development side, so companies like Ortho that are producing these phenomenal drugs, but that you can get them. Because again, as we said, it could be the best drug in the world, but if you can't access it, then what good does it do you? And so the NPF is there lobbying in Washington and in your state legislatures to guarantee that those therapies are available for you. Again, the NPF Patient Navigation Center, where you can get some personalized assistance to help you find solutions to live your healthiest life. And then talkpsoriasis.org is an online support community where you can connect other people with psoriasis, because it's not always easy to talk to your physician. You may feel that you get rushed or don't have a lot of time with him or her, and you can gain a lot from engaging with your peers and other people around the country and around the world who suffer from this disease and may have some interesting stories to tell that relate to yours. So you want to continue your journey to clearer skin, and let's just sort of review some of the things that we talked about today. Plaque psoriasis is an autoimmune disease triggered by a combination of genetics and external factors. It is not infectious. You are not contagious. And that's really important to note and to share with those who may be a little concerned. Plaque is a novel medication for patients with moderate to severe psoriasis who have tried another systemic therapy that doesn't work or stopped working. And in fact, Plaque works differently from any other psoriasis medication by blocking a specific set of proteins at the site of inflammation. So as we said before, think of Plaque as blocking the lock that allows some of those inflammatory triggers or keys to get in. By blocking the lock, not allowing those inflammatory triggers through the door, it makes sure that, in fact, the psoriasis plaque cannot begin or be maintained. In clinical trials, many patients taking Plaque showed rapid, lasting results. Some people taking Plaque have had suicidal thoughts or ended their own lives. This risk is higher if you have a history of suicidal thoughts or depression. And last, the most common side effects, as was discussed earlier, include joint pain, headache, tiredness, diarrhea, mouth or throat pain, nausea, muscle pain, injection site reactions, flu, low white blood cell count, or fungal infections of the skin. So in short, you really want to ask your healthcare provider if it may be an option for you. And with that, I know it's a difficult process, but I'd love to hear if there are any questions and sort of discuss what's most important to you on this call.
Thank you, Dr. Weiss. If you do have a question, feel free to submit that under the chat on the question function under your control panel. A few have come in. One participant asked, how is Plaque different than the current therapies on the market?
Right. So as we sort of discussed, there are a handful of different classes of treatments. So you have TNF inhibition, and those are the Humira and Enbrels of the world. You have IL-12 and 23 inhibition, which is the Stelara and Tremfyas. And then you have IL-17 inhibition, where you're attacking IL-17 directly, so the key, so to speak, which is Taltz and Cosentyx. And then now you have Siliq, which is blocking the lock. It's an IL-17 receptor antibody. So it is unique in the fact that it's blocking the receptor to IL-17 as opposed to IL-17 itself. In the non-biologic class, so small molecule, you have Otezla, which is a PDE4 inhibitor, and then you have the older line therapies like methotrexate, cyclosporin, Puva, narrowband UVB, and of course all of the topicals.
Great, thank you. Another question that has come in is, does it stop working over time?
So what we know from the clinical trials is that over time it improves, at least up to 1 year. Siliq is a newer medicine, so it's difficult to state what occurs at 3, 5, or 10 years. But we know from the clinical studies at 1 year, it improved to the point where roughly half of the individuals achieved a PASI 100 or complete clearance.
Great, thank you. Another question that has come in is, do the side effects go away after taking it for a while? Do they get worse, or is the side effect profile at random?
So it's a great question and very difficult to answer. So certain side effects are the nature of the drug. So you are at an increased risk of infection as long as you're on the medicine. Some of the other side effects are probably more dose dependent, but again, we can't confirm that. So there's a collection of side effects with any of the biologics that are due to the way they work or their mechanism of action by impacting the immune system. You are at an increased risk for infection. Things like cough or muscle aches are probably more due to the drug itself, and we can't really state with any certainty whether they get better or worse over time. It's probably very individualized.
Great. Another question that has come in is, in your opinion, is Siliq more efficacious than other biologics on the market?
Again, it's very difficult to state that. You can only look at clinical trial evidence, and that's a hard thing to compare. What we can say is that Siliq provided 40% PASI 100 versus Stelara, which had about a 20% PASI 100 in this particular clinical trial, where the inclusion and exclusion criteria were the same. But otherwise, it's very hard to compare across drugs.
Great, thank you. Let's see, next question here. Were there people who had no side effects after taking Siliq?
So when we reviewed some of the most common side effects, they were actually in a relatively small percentage of the population who was on the drug in the clinical trial. So that would be 10% or fewer. So there were individuals on the clinical trials, I don't know those numbers off the top of my head, that did not experience any of those side effects.
Great, thank you. Next question here, just asking you to please review again how often Siliq is administered.
So again, there's a loading dose where you take it at what we call time 0, 1, and 2. So the first 3 injections, and then every other week thereafter. So you can think about it as a twice-a-month therapy.
And then one of the questions was referring to Siliq Solutions and the cost, which NPF can address. If eligible, on SiliqSolutions.com or on Siliq.com under Siliq Solutions, it does state that if eligible, you may pay only $5 per month. And then if there are coverages delayed or denied, you may only pay $25 per month until the coverage is approved for up to 12 months from the program. Again, you have to fill out forms and talk to the folks at the Sleek Solutions, and they can help make sure that you have a cost-effective way of obtaining the medication.
So I would agree. I mean, I think that if you fill out the paperwork as indicated on the website, there's a whole team of individuals that will work with you to do everything they can to make sure that drug is available to you at a reasonable cost point.
And then the last question was can you remind the participants on the line if Sleek is an auto injector?
So it is not as a pre-filled syringe. So it is not in what we like to refer to as a pen, sort of like the EpiPen. It is in fact a syringe. It's already pre-filled for you that you would inject yourself.
Great. And then the last question that has come in, if you could give your insight around, does Sleek help lessen joint pain or effective for psoriatic arthritis?
So it has not been studied in psoriatic arthritis to this point here in U.S. clinical trials that we would have data available for you.
All right, we're going to do one last call for questions. At this time, there appears to be no more submitted questions, so thank you, Dr. Weiss, so much for this wonderful presentation. Again, for further information or to find a provider that can prescribe Sleek, please visit sleek.com. This webinar has been recorded and will be shared with attendees in the next few days. You will also be receiving an evaluation survey that will be sent to the email you registered with for the webinar. Please take a moment to fill this out on behalf of the National Psoriasis Foundation, Dr. Weiss, and Ortho Dermatologics. Thank you all and have a great evening.
Great. Thank you very much.